Academy Vaginal Surgery Masterclass series. In this series, we are going to learn about pelvic organ prolapse repair, anterior, posterior, and apical compartment techniques. So, what we are going to learn, number one, foundation. We should know about the POP definitions, POP, Q staging, epidemiology, risk factors, and relenses levels of vaginal support. Number two, we will learn about the evaluation. What are the structured preoperative assessment? What is the staging? What are the guide compartment specific surgical planning? Number third is anterior compartment, cystocele anatomy, step-by-step anterior colporaphy techniques. Fourth is the posterior compartment. We will learn about the rectocele anatomy, posterior colporaphy, perineuraphy technique. Then apical compartment, it's a uterine vaginal wall prolapse and comparison of sacrospinous, uterosacrals, and Meckel's approaches. And decision-making and outcome. What is the approach? What is the native tissue versus MASH evidence? What are the complications? What is the recovery, recurrence, and data? So the foundation is understanding pelvic organ prolapse. Definition is pelvic organ prolapse is a descent of one or more pelvic structures, especially the anterior vaginal wall, that is bladder, posterior vaginal wall, that's rectum, uterus, cervix, or vaginal wall, into or beyond the vaginal canal, resulting from the loss of normal pelvic floor support. Those are fascia, ligaments, and levator musculature. Now, the common presenting symptoms are that's a vaginal bulge or something coming down, pelvic pressure worsening with standing and straining, voiding or the defecatory functions, and sexual dysfunction or dyspareunia. Now, POP-Q staging overview is 0 is no prolapse demonstrated, 1 is leading more than 1 centimeter above the hymen, 2 is leading edge within 1 centimeter of the hymen, proximal or distal, 3 is leading edge is more than 1 centimeter below the hymen, but less than TBL minus 2 centimeter, and 4th is a complete eversion or procedure. Then epidemiology and risk factors, up to 50% prevalence on the pelvic examination versus 3 to 6% defined by bothersome symptoms. So in a 50% patient don't talk about anything. 20% lifetime risk of undergoing surgery for POP and stress incontinence by age of 80. 30 to 50 years peak burden considered in women aged 50 to 59, incidence rises sharply after 40. Now, these are the established risk factors. First is vaginal parity and delivery. Chronic straining may be constipation, cough, advancing age, and menopause. Any prior or pelvic hysterectomy surgery leading to wall prolapses, obesity, elevated BMI, and connective tissue weakness. So, relenses 3 levels of support. Level 1 is suspension. They are uterosacral and a cardinal ligament complex. The cervix and upper vagina from sacrum to lateral pelvic side wall. Loss here produces uterine or vaginal wall prolapse. Level 2 is the attachment. The mid-vagina is attached laterally to the arcus tendinous fascia pelvis and rectovaginal fascia. These loss produces anteriorly as cystocele and posteriorly rectocele. Level 3 is a fusion. The distal vagina fuses directly to the perineal body, urethra, and levator muscles. Loss here contributes to the urethral hypermobility, perineal body deficiency. Now, preoperative evaluation and staging. First, we should know the proper history. What are the bulge symptoms, voiding, defecatory functions? What is the sexual functions, obstetric history, prior pelvic surgery, medical morbidities affecting healing. Examination, supine as well as standing examination with Valsalva, split specular examination, anterior and posterior vaginal wall, assessment of affects and perineal body and elevator tone, POP-Q staging, formal 9-point measurement, especially including all, to objectively stage each compartment and standardize the documentation. And adjoint testing is urodynamics. If occult stress incontinence suspected, cuff stress test with prolapse reduced, imaging reserved, and a complex recurrent cases. Staging directly informs surgical planning. Isolated single compartment defects may warrant repair, focused repair, while multi-compartment disease seen in majority surgical candidates require a combined approach. So now we will talk about the anterior compartment, that is a cystocele, anatomy and repair principle. What defines cystocele? A cystocele is a descent of anterior vaginal wall, overlying bladder base, resulting from the defect of pubocervical fascia and its lateral attachment to the arcus tendinous fascia pelvis. That's a level 2 support. These defects may be central, that's a midline, or a lateral, paravaginal, or the combination of both. It can be central because of the midline attenuation of the pubocervical fascia, lateral because it's detachment from the white line, that is the arcus tendinous, and transverse separation of the pericervical ring apically. Repair principle is restore fascial support by plicating and reinforcing the pubocervical fascia in the midline, identifying and correct the specific defect, and midline plication alone will not fix the paravaginal defect. Reduce the redented vaginal epithelium without over-narrowing the canal, and assess and address the apical support concurrently, anterior recurrence linked to the untreated apical disease. Native tissue repairs, a first line, mesh reserved for selected and recurrent cases. Now, anterior colpography, there is a technique. First is a positioning. Number 2 is a vaginal incision. Third is a fascial plication. Fourth is a paravaginal repair. And fifth is a trim and a closure. And sixth is the cystoscopy and catheterization. Positioning is very, very important. Infiltration, if you want to do it, otherwise cannot be done. Incision is a midline incision below the bladder neck to the apex, and a blood excision separate the vaginal epithelium from the underlying pubocervical fascia. Then facial plication, identifying the facial defect, place the interrupted absorbable delayed sutures in the midline to plicate the pubocervical fascia, reducing the bladder. Then paravaginal repair is needed for lateral defects, reattach the fascia to the arcus tendinous fascia bilaterally to restore the lateral support. Then excise the redundant vaginal epithelium conservatively, close the running absorbable suture, avoid excessive neuroid. And cystoscopy is needed. Now, after the anterior compartment, there is an posterior compartment, that's a rectocele, anatomy and repair. It's a rectocele is a herniation of anterior rectal wall into the vaginal lumen through the defect of rectovaginal fascia. That's a denovularis fascia. It typically resulted from the attenuation, tearing, or the detachment of the fascia from the perineal body or the apex, often compounded by chronic strain. Findings are splinting to complete defecation, deficient or attenuate perineal body, and enterocele may coexist, might be identified and reduced. Now, the principles for the repair are reconstruct the rectovaginal fascia support with spite-specific and midline plication, reduce and ligate any enterocele sac before the fascial repair, rebuild the perineal body by deficient to restore the distal vaginal axis, avoid levator plication in the midline, over-plication risk of dyspareunia is not routinely recommended, and address the apical support concurrently when present, as posterior recurrence is linked to unaddressed apical disease. Now, posterior colpography, again, exposure, vaginal incision and dissection, enterocele management, fascial plication, perineal reconstruction, closure. Exposure, again, put the patient in a proper positioning. Incision is a midline or a triangular incision in the posterior vaginal wall. Dissect the vaginal epithelium and underline the rectovaginal fascia. Then, if present, isolate the peritoneal sac and reduce the content and ligate and excise its neck before proceeding. Then, fascial plication, place interrupted suture on the rectovaginal fissure in the midline, site-specific, to restore the fascial layer over the rectum. Then the perineal body, approximate the bulbocavernous and transfer perineal muscle to the midline and rebuild the perineal body height of the support. And closure, trim the excess epithelium and rebuilding the abdominal suture, access the caliber, intraoperative procedure. Now, perineorrhaphy technique is a perineorrhaphy rebuilds the perineal body, fibromuscular junction of bulbocavernous, transverse perineal and external sphincter muscle, restoring the distal vaginal axis, genital hiatus, and posterior fascial support. It is frequently performed with the posterior colpography, but can be isolated procedure for perineal body deficiency and rectocele. So key technical point is excise a diamond shape of the perineal skin, posterior hymen remnant, identify and reapproximate the bulbo cavernous, calibrate the genital hysis intraoperatively, avoid incorporating external enamel sphincter defect, especially being repaired, and counsel the patient post-operative for the sexual consent sensation practice. Now, after the anterior and posterior compartment, we will deal with the apical compartment. That's a uterine and wall prolapse overview. Apical prolapse reflect loss of first suspensory ligament, uterocardinal ligament complex, allowing the descent of cervix and uterus. For vaginal wall, after the hysterectomy, is critical driver and anterior and posterior compartment recurrence that must actively assessed in every prolapse evaluation, not just the apical descent, it's a primary component. So prolapse is a descent of intact vaginal axis. Management options are uterus preserving, hysteropaxy, or vaginal hysterectomy with apical suspension and a factor. But for vaginal wall prolapse, we have to do the sacropulpopaxy is needed. Apical perpend subsequent overview, what we can do, how are the anatomic attachment, and what are the considerations. Sacrospinous fixation, its approach is vaginal. Sacrospinous ligament, bilateral or bilateral. Comparable success, shorter operative time, risk of the buttock tail, pudendal nerve injury. Some studies show higher anterior recurrence. Uterosacral ligament suspension, vaginal. High uterosacral repellents bilaterally. Restore near vaginal axis, and there can be a chances of urethral kinking or intraoperative patency should be checked, and success rate is good. Mechal's scaldoplasty is a uterosacral placated into midline, obliterated the caldostac, and it can be done concurrently with the vaginal hysterectomy. Now, with choosing the right compartment approach, most surgical candidates are a multi-compartment disease. So, decision making for the POPQ staging along the compartments, what is the patient's goal, sexual activity, uterus preservation, recurrence, all are important. So, isolated repair we can do individually for stage 2 cystocele and nothing, and normal apical segment combined with hysterectomy, anterior posterior repair, and can be done. And then the sequential is occasional in the frail patients. We need not to do anything and just close it. So that's another important. So these are the we don't use nowadays the mesh, but still there are negative tissue repair are better than mesh repairs. Now complications and management, hemorrhage is very much important. Bladder injury is another. Urethral injury in kinking is important. Rectal injury and nerve vessel is there. So hemorrhage is we need a meticulous dissection, place identification, cure hemostasis, either with the electrocautery, suture, ligature, whatever. Bladder injury, during the anterior dissection, we should be worried about. Same with urethral injury and rectal injury. Post-operative care and recovery, immediate, monitor for breathing. Early 1 to 2 pelvic rest, no intercourse. Immediate 2 to 6 gradual increase of activity. And long-term 6+ weeks, resume the intercourse with full activity as the clearance. Now, outcome and recurrence are the key predictors. Preoperative stage 3rd and 4 prolapse, most commonly confirmed risk factors. Younger age, less than 60 at the time of vaginal surgery are important. Now, these are the clinical judgments, pearls and pitfalls. Always stage all 3 compartments. Isolated repairs fail when apical loss is missed. Perform exam with the patient standing and straining, unmask the mesenchymal prolapse, intraoperative cystoscopy after any apical suspension. Reconstruct the perineal body and it restores the vaginal axis, just not the cosmesis. Counsel every patient on a modifier recurrence risk and important. Overplacating the anterior or posterior fascia causing vaginal stenosis. Treating anterior compartment in isolation while ignoring the apical descent is leading cause of early recurrence. Midline elevator plication for rectocele repair, increased dyspareunia, and placing sacrospinous suture 2 in the extreme spine, risk of pudendal nerve injuries, and routine use of synthetic mesh, which we don't use primary anterior repair, despite the guidelines against. So summary and a closing are, POP is common and multi-compartment. Stage all 3 levels, anterior, posterior, apical, before planning the surgery. Darlency's 3 levels of support explain why isolated compartment repair often fail without apical correction. Native tissue remains the first line for anterior and posterior compartment. Sacrospinous fixation, uterosacral suspension, and Meckel's scaldoplasty after comparable native tissue opile suffered is an option. Preoperative stage 3 and 4 disease is most common consistent predictor of recurrence. Set expectations accordingly. Meticulous technique, intraoperative cystoscopy, structured postoperative care minimizes complication and reoperation.